for coming today. I'd like to introduce Dr. Corsello, who's going to be discussing atrial fibrillation prevention today. Dr. Corsello attended SUNY Buffalo School of Medicine. He completed his medicine residency at Strong Memorial Hospital, and that is also where he completed his fellowship in cardiology. And he is a member of the Maine Medical Partners Cardiology Group and is the EP Lab Medical Director. So thank you very much for coming back to Dr. Corsello.
No problem. Thanks for reminding me. I've been here 15 years, so I forgot most of that. I actually did internal medicine, cardiology, NEP, so 8 years in Rochester. Just kind of got stuck there. So what I'm going to talk about today is atrial fibrillation. And there's kind of been a sea change in thinking of atrial fibrillation and its treatment within the past few years that I want to make sure I shared with you, and how we can think about atrial fibrillation as a syndrome, not just a single disease. My obligate disclosures, I have no financial relationships relevant to this discussion. We do have research projects sponsored by a few companies. That's not going to affect what I'm going to talk about today. And I feel that it is only right to talk about off-label products, certainly in a field like mine, where labeling does not keep up with medical science. For example, the first VT ablation was in 1984, but we didn't have a catheter labeled for that until 2006. And it took 11 years for the FDA to catch up to label a catheter for AFib ablation. And this is, part of a project, a clinical transformation project that Maine Health has sponsored and endorsed. And a number of us are working very hard at the transformation of the care around atrial fibrillation. And so what I'm going to talk about in summary is AFib as a syndrome. And in the past, what we used to do, including a couple of weeks ago, one of the outside cardiologists gave me a call and said, patient has AFib and his echo's fine, his PSH is fine. You go ahead and treat him and ablate or do something else. We're going to talk a little bit about a project called the Clinical Transformation Project and get with the guidelines, which is one of the major parts of this later on. I'm going to give you an update on stroke prevention and talk about the Watchman device. And if time permits, I'll talk about a convergent maze for long-term persistent atrial fibrillation. So when we think about someone with atrial fibrillation, as I mentioned, it should no longer just be do they have a cardiomyopathy or thyroid disease, but there are reversible, treatable, preventable causes of AFib, like weight, under or over conditioning, blood pressure control, alcohol abuse. There are some people who have atrial fibrillation because of a family history, and the genetics are just starting to get worked out about that. And then it is a great example of where shared decision-making helps. I won't cover that too much today. And we'll talk about both the primary and secondary prevention of atrial fibrillation. I'm intentionally not going to cover AFib caused by coronary disease, age, because we can't change that one, heart failure, hyperthyroidism, hypertrophic cardiomyopathy, or valvular heart disease. And the way that I'm going to talk about the syndrome of AFib and the secondary care is I'm going to spend about a half an hour on this slide. Right here. Just give me a second to load this up. Do I have a working mouse? Yes. I just want to, this would click it to full screen again. Like we're locked. Where?
Oh, probably down in the bottom left corner.
I don't see it. Go ahead. Oh, no. I mean, I want to be presenting locally on the web here, I think. Fun for those outsiders. We had this working just 5 minutes ago, maybe 10. No. Back up. So it's this one here. Maybe we can just is that?
Really, home.
No, so we've locked this whole, our internet is locked. Okay.
Refresh it.
Oh, thank God. So what we're going to talk about is, as I was starting to say, atrial fibrillation, the primary and secondary causes of atrial fibrillation that are treatable. And one of the first things I want to talk about is obesity, which plays a large role in atrial fibrillation. If you look, for example, at the Women's Health Study that followed patients for more than a dozen years, if you were overweight, you had a 20+% increased risk of atrial fibrillation, 65% increased risk if you were obese, and a almost 5% increased risk for every point in your body surface area that went up. So the folks in Adelaide, Australia, started us thinking more carefully about obesity and its treatment in the role and its role in atrial fibrillation with a study that was in JAMA 3 years ago. And what they did is pick 150 patients, and conveniently, there's an 8-month wait for an AFib ablation in Adelaide, Australia. So they used that waiting phase to enroll some people and randomize them to very, very aggressive risk factor modification versus usual care. So just to outline usual care, it's what we all do. They come into your office, they're overweight, you say, lose weight, come back in 3 months. That's the standard of care, the control group. And the intervention group was weekly visits with nurses, dietitians, exercise physiologists, and they worked on a number of risk factors. Weight loss. If you didn't lose weight successfully, they substituted your breakfast and lunch with protein-rich shakes. They worked on diabetes control, lipid control, hypertension control, alcohol counseling, screened for sleep apnea and treated if necessary, and worked on exercise. And so what you can see above is that the intervention group went from a starting weight circumference of 110 down to 92, from a weight of 99 kilograms down to 80, which is a fairly impressive weight loss. Hopefully. I'm having a lot of fun with this so far. Okay. So very impressive weight loss from 99 kilograms to 80. BMI went down from 32 to 27. I should mention all these patients started above 27. And in the control group, you had a small weight loss, small decrease in waist circumference, but not so impressive. And what they showed is the amount of atrial fibrillation went down more than with most antiarrhythmics or catheter ablation alone. So people who, at baseline in the intervention group, had an average of 3 episodes of atrial fibrillation per month went down to less than 1. The amount of atrial fibrillation on Holters went down by more than 50%. And the number of people with more than 1 episode per month went down from 65% to 21%. In the control group, it changed minimally, if at all. The duration of AFib, amount of time in AFib went up and showed what we see more typically. So weight loss alone, without any intervention, treated atrial fibrillation very well. And they quantitated this with risk scores. Bariatric surgery, by the way, also treats atrial fibrillation very well. We won't go into that in too much detail. So they talked about exercise, and I'm going to show you in just a minute. Thank you for the segue. So they then tried to tease out what is causing this, and they did a number of different follow-up studies. This one, they took patients referred for an ablation directly, not just referred to them, and offered them risk factor modification using the same program. Now, this time, they had 96 people who declined, not randomized, and 69 people who accepted the risk factor modification. Again, they showed relatively similar effects from the risk factor modification. BMI went down not quite as much in this series. Blood pressure went down. Remember, officially with diabetes went down, and not so much in the control group. They then looked at the amount of people with atrial fibrillation, which is shown on the curves below. And I'm going to show a number of curves like this. what you want is to be 100% without atrial fibrillation. The red curve is patients who went on for an ablation and the success rate, which is approximately 60%. The blue curve is people who had an ablation and they had about a 20% success rate from that ablation by not losing weight. So even if you have an ablation, losing the weight and modifying the risk factors makes a big difference. Now you look over here at patients who had multiple ablations, so some people require 2 or 3 ablations and an antiarrhythmic drug. If you lose the weight, you get a pretty similar success rate to what we see in other series of non-obese patients, which you can get up to about a 90% success rate with the Iwo Jima approach, with procedure after procedure and drugs if necessary. You never quite get to 100%. I can talk a little bit about that later. On the other hand, if you don't lose the weight, you don't even get a 50% success from multiple procedures and maintaining on antiarrhythmic therapy. So as this group, and then they added on the group from Melbourne as well, tried to tease this out. They looked at a number of different factors. This study looked at same type of intervention. This time, what was the success rate? First, on the left, ablation-free, drug-free, based upon whether you were successful at losing the weight. So not just an intention to treat, you're in a risk factor modification, but was it the weight loss that seemed to correlate with the improvement? The curve in red on the top is more than 10% weight loss. That's a lot, obviously. People without drugs or any interventions had a 50% success rate of not having recurrent atrial fibrillation. On the right, this shows, again, multiple procedures and with antiarrhythmic therapy. If you lost the weight, you got up to that magical 90% number. If you didn't lose the weight, 60% chance you're going to have recurrent AFib despite every procedure and drug we can throw at the patient. So they also noticed that weight fluctuation, so those people we all have, where weight goes up, down, up, down, up, down, up, down, they did much worse than people that just lost weight. So to take this even further to try and understand the concept, they established a sheep model. That's what you do in Australia. You need to do an animal model. And what they did is 10 sheep were the control group. They fed them on alfalfa. And 10 sheep, they gave them calorie-rich pellets, which I imagine is skillets, to their feed. And they overfed them for a period of months and then sacrificed the animals and did EP studies on them. And what they showed, as we see in obese humans, is that they had an accumulation of fat on the pericardium and in the pericardial space and epicardium. And what's shocking, and I think scary, is these white areas on this stain are fat and the red are muscle. So this is the baseline. The fat has actually grown in between the muscle cells and explains something we see clinically, which is that there's lower voltage poorer conduction, and on MRI, there's evidence of fibrosis, tissue in between the muscle cells when you have obese patients or patients with atrial fibrillation. So simply a period of months was enough to cause fat growing into the muscle cells. They showed that the fibrosis went up, and in an abstract not yet published, they showed that the fibrosis can go down in these animals if they lose the weight again. So it is a potentially treatable and reversible cause. And then at EP study, they showed exactly what we see in clinical AFib. To be clear, these animals did not yet develop AFib. It was trying to understand the concept of what's causing the AFib. But if you did an EP study, you saw all the same kind of stuff that we see in humans who actually have AFib. So weight clearly plays a big role, and weight loss dramatically affects outcomes no matter what you do. And it is a teachable moment. I probably have a lot of these clinically, where someone who is miserable from their AFib is more likely to be receptive to your suggestions than someone who is not. It's not just the concept, and I will tell you, I have, up till a few years ago, never been successful at getting anybody to lose weight, certainly not for coronary disease remote from an MI, but when you can say, look, your AFib right now is from your weight, and if you lose your weight, there's a 50-50 chance you won't have AFib to a clinically significant degree. We have some people who take that on. And I'm going to show you some of the things we'll can do to help them along. Deconditioning also plays a role. And so if you look at, again, these same series, I'm going to show this in 2 ways. you were asking before about exercise and other things. So this was very aggressive risk factor modification in the first and second study, and then they tried hard to tease out what's playing a role. Now realize that these patients had all of the measures at risk factor modification. But if you looked at the people who improved their fitness during a few-month trial, they had less atrial fibrillation. Similar curve, similar setup. This is ablation-free, drug-free, AF-free. And if people gained fitness, so their serial treadmills went up by more than 2 metabolic equivalents, they had a lot less atrial fibrillation than if they didn't. By the way, if you look at the newest technology for AFib compared to older, if you look at the highest volume center compared to the lowest, the curves are right next door to each other. They're 5 percentage points off, 10 percentage points, maybe 15 percentage points. If you look at weight loss, they're 30, 40, 50 percentage points off. So the order of magnitude is completely different from non-interventional things. And so they looked at people, again, on the right, similar display, total AF freedom. If you gained fitness during the trial, I'm really enjoying this mouse here. So thanks, guys. So if you look at people who gained fitness, they had that magical 90% success rate. If you look at people who did not, they didn't have so good a success rate. They also looked at baseline fitness, which played a role as well. Of course, these things are connected. They're more compliant. If you're not quite as obese, you can exercise more. If you exercise more, you might not be quite as obese. So we haven't quite separated out which is the true factor, and maybe it's all at the same time. But if you look at people who were very unfit, couldn't reach 85% of max predicted, despite multiple procedures in antiarrhythmic therapy, they're again getting down to that abysmal 20% success rate from tons of ablations and tons of medication. So fitness plays a role as well, both baseline fitness and the ability to get fitter. Now, it is not just in Australia this is true. So in Detroit, they looked at something similar and analyzed in a different way. They took 64,000 people who had stress tests in their database and then used administrative database, meaning something similar to Medicare data, to see the risk of atrial fibrillation over a decade based upon your baseline fitness. And what they showed is the fitter you are, so if you got to more than 11 METs, your risk of atrial fibrillation was very low, only a few percent. If you couldn't get to 6 METs, risk of atrial fibrillation at 10 years is 25%. Now, this is all comers for a stress test. So some of them might have coronary disease, some of them might have heart failure. Many would have other comorbidities that play a role, but the stress test alone predicts their success. And it's sort of in a hypothesis-generating, very small study from Circulation just a couple months ago. They took a small group in Europe, took 51 patients who had atrial fibrillation and implanted a loop recorder so they could very carefully quantitate the amount of atrial fibrillation. Then they had a control group who had usual care, and half of them were randomized to interval training, just a few-minute intervals at 90% max predicted heart rate, alternating with rest, 3 or 4 sets of these, 3 to 4 times a week. In 12 weeks, you saw a decrease in the amount of atrial fibrillation. Nothing else was changed. The interpreter of the EKGs was blinded. The patients, of course, were not blinded. So in the control group, you saw a 4% increase in the amount of atrial fibrillation by the very detailed implantable loop recorder. In the exercise group, the amount of AFib went down by 3%. Sort of further reinforcing that conditioning plays a big role. So what have we done to address this? So the cardiac rehab program, as part of Turning Point, now has an AFib cardiac rehab. So you can enroll them, and certainly contact our office. This is something funded partially through a grant, and then the patient pays, I think it's $60 per month, so slightly paid. There are 2 nutrition sessions with it. There's a couple of other education sessions, but the primary component is a non-supervised exercise. Right, non-supervised meaning it's not phase 3 cardiac rehab after a heart attack, after CABG. It's allowing them to exercise in your gym with a little bit of coaching. And so they looked at, there is a small study, got a small grant, and I apologize for mangling Chuck Carpenter's name. Not as easy to fix in this software as it should be. But they got a small pilot grant, which we've enrolled 16 patients, and they're going to look at whether this program affects their quality of life, their 6-minute walk distance, whether dietary counseling and other things helps. So they enrolled at last time, I got an update, 28 patients in this protocol. We are looking for more. So the cardiac rehab folks are absolutely thrilled to be able to offer this for patients. They're more enthusiastic, you know, Gail is more enthusiastic than we are in a way, which is just great. So we talked about obesity and deconditioning. I want to talk about some of the other factors that play a role and can be treated. The next is sleep apnea. So if you look, the Mayo Clinic folks took a whole bunch of sleep studies. And if you live around the Mayo Clinic, you're getting a study. So this particular study, they looked at people who had a positive versus a negative sleep study. So everyone was referred for a sleep study. And the people who had a positive sleep study had a much higher rate of atrial fibrillation over time than people who did not. This has been shown repeatedly. And the severity of the sleep apnea, as well as obesity, play a role in your risk of atrial fibrillation. So on the left, you see people with a very low apnea-hypopnea index. Blue, you have people who are BMI less than 25. Green is greater than 30. As you go from left to right, the worse the sleep apnea and the bigger the patient, the more likely you are to develop atrial fibrillation. So as high as 20% of people who are both obese and have sleep apnea. And not only are they more likely to develop sleep apnea, they're more likely to develop AFib. They're more likely to develop refractory AFib. So if you look at paroxysmal atrial fibrillation versus persistent, the worse the sleep apnea, the higher the apnea-hypopnea index, the more likely you are to develop the worst kinds of atrial fibrillation. If you look at success rate from catheter ablation, it is dramatically changed by the treatment of sleep apnea. Let me take you through these 4 curves in a second. If you look at the average series of AFib ablation right now, for example, New England Journal of Medicine published the Fire and Ice trial a couple of weeks ago, which was cryo versus radiofrequency catheter ablation. Success rate is about 65%, which is pretty typical for that type of series. If you don't have sleep apnea, or you have treated sleep apnea, that's your success rate of catheter ablation at the Beth Israel. If, on the other hand, you have untreated sleep apnea, success rate is about 30%. Matter of fact, it's the same as if you do nothing and don't get a catheter ablation and don't have sleep apnea. So we are trying to be very, very aggressive about thinking about sleep apnea and screening for sleep apnea. This has been reinforced by the group out of Texas as well. Metabolic syndrome is a predictor of worse outcome, as is sleep apnea. And this has also been shown in an animal model to probably be the apnea itself. So it's both the obesity and the apnea. You take some poor animals and put in what sounds like a tracheostomy and intermittently shut it off during sleep. I'm sorry, I didn't do it. You will get the same electrophysiology changes, and you will get inducibility at an EP study of atrial fibrillation when the normal heart you cannot. This doesn't occur in the sham ones who just have a tracheostomy without it being closed. So what we all want to do is, if you hear atrial fibrillation, you want to think about these other treatable secondary prevention, but you also want to think very hard about sleep apnea. So I thought I'd look to the American College of Chest Physicians for clarity on how to screen for sleep apnea, and this is what they call clarity. Not very clear to me. The only thing I can say as someone who doesn't specialize in sleep apnea is you got to think about it. You know, we use a stop-bang thing. I think all the EPs now, it is routine to, at a minimum, ask about daytime hypersomnolence. And it is unfortunate, but it's not unusual to be the 3rd or 4th provider to be the first one to realize that they probably have severe sleep apnea, that AFib is just a manifestation of it. Hypertension, of course, plays a role, but what may not be as obvious is that the treatment we choose for hypertension plays a role in the success of the treatment of their atrial fibrillation. If you look left, right, forward, and back, according to the Framingham study, one of those people around you will have atrial fibrillation in their lifetime. If you start out with a group in their 40s. So it's about a 25% risk lifetime of developing atrial fibrillation. Most of that time it's at an older age. And the higher the blood pressure, the higher the risk. So this risk increase is not quite as profound as I showed with sleep apnea or with obesity alone. When you look at people with the metabolic syndrome, it looks like all of the components play a role. So it isn't just the obesity, the increase in waist circumference, or the hypertension alone. The more components of the metabolic syndrome you have, the higher your cumulative risk of developing atrial fibrillation. So if we go back to the original study I showed, there may be some benefit from more aggressive diabetes treatment, more aggressive hypertension treatment. It may not just be the weight and the fitness that was playing such a role, although those two clearly are components. Drug choice affects the amount of atrial fibrillation people have. The probability of having atrial fibrillation is less on ACEs and ARBs. This is one of the community that's a little different from what the literature supports. So if you look at multiple studies, so many studies that it's a meta-analysis, if you treat someone with an ACE or an ARB who has hypertension or heart failure, their risk of atrial fibrillation goes down. I don't know. It seems to me when you have atrial fibrillation, people say beta blocker, they say calcium channel blocker, and there's no question those lessen the symptoms in AFib. They control the heart rate in AFib. But if you have to choose a drug, for example, in a heart rate controlled patient or a very infrequent AFib patient, ACEs and ARBs are better. So ACE and ARBs have 50% or so reduction in the risk of atrial fibrillation. In multiple studies, either primary prevention or secondary prevention of atrial fibrillation, right? So that's usually we think primary and secondary prevention of like coronary disease or something. There's primary and secondary of atrial fibrillation as well. And this is a benefit beyond what you see with calcium channel blockers, again, in the heart failure hypertension population, beyond what you see compared to beta blockers. So in the hypertension and heart failure patients, you want to think about ACEs and ARBs. Now, unfortunately, this doesn't work in people who don't have heart failure or hypertension. So in a mega trial out of Italy, if you look at patients who just have atrial fibrillation and you give them an ARB or nothing, there's no difference. So the patient who has AFib with no other conditions, a beta blocker and calcium channel blocker makes sense, but not when they have other treatments. And the control of blood pressure matters too. This is a confusing study I don't want to go through in detail, but the folks out of Texas looked at a number of patients with atrial fibrillation, and they called uncontrolled hypertension if they're on 3 or more drugs and arrived at their clinic with a blood pressure over 140 and 90. Now, they're an international, a national referral base, so people are flying and stressed, and who knows what that one sample blood pressure means. However, if you look at people who have uncontrolled hypertension, they had a much lower success rate as compared to people who had controlled hypertension. So hypertension control matters. We had some questions earlier before we started about the genetics of atrial fibrillation, and the understanding of the genetics is pretty primitive. If you look, for example, at large populations with atrial fibrillation that were screened, about 20% will have genetic variants of some of the cardiac ion proteins. What those genetic variants mean is not yet clear, but certainly when you have an AFib patient, the family history questions, as my partners do, should not be about coronary disease. The family history questions should be about atrial fibrillation, because that can help understand, because there should be fewer and fewer patients that we blame AFib on lone AFib. There's got to be something causing AFib in any one patient. And the understanding is primitive, but getting more sophisticated. This group looked at a family that coincidentally would have AFib in the family members that had a hypertension, but not in the family members that did not. So they purified out that protein, put it into a cell clamp, and realized that if the cell was stretched, the conductance changed. Only if the cell was not stretched, the conductance was the same as normal. So you needed both an environmental and a genetic component in order for them to develop the clinical symptoms. The beverages we drink play a role in our atrial fibrillation and a burden of atrial fibrillation. And I was so thrilled to learn that caffeine has no role. If you look at a European series where people drink espressos and lattes more with up to 10 cups of coffee per day, no clear increase in the amount of atrial fibrillation. This is a meta-analysis of hundreds of thousands of patients. Now, there are case reports of people taking massive overdoses, for example, of energy drinks, where they've had arrhythmias of various kinds, but the usual person is not going to be subjected to that. So we don't need to cause caffeine teetotalers. in patients who have atrial fibrillation. Alcohol is the opposite. Alcohol definitely plays a role. 1 or 2 drinks a day probably has no effect. I say probably because there might be a little signal of a 5% increase risk in meta-analysis, but not in any individual study. More than 3 drinks per day definitely plays a role. And there's even the holiday heart syndrome, which is poorly and vaguely defined in the literature, but probably more than 5 drinks triggering atrial fibrillation in people who have no AFib when they don't drink. And I have multiple people like this. They might go years of not drinking because they hate their AFib, and then they'll just go to a ball game, have some fun, and they're back in the ER again. And that may take multiple days of multiple drinks to have it, but they can be purely alcohol triggers. Now, if you look, I didn't show it, but if you look at the success rate of AFib ablation, and I keep coming back to that partly because that's where we have most of the data, that's where a lot of the passion is, because a lot of the ablation is like, why didn't this work? I did the same thing in 1,000 people. Why did it work in these people and not the others? If you have more than 2 drinks per day, the success rate is less than if you have less than 2 drinks per day. So we want to be careful about counseling those patients as well. As we try to explain AFib at every single patient that comes through our door, there is an AFib phenomenon of overconditioning. And I'll just show 2 series, although there's many in the literature, to show you that that is true. Folks in Switzerland took professional cyclists who participated in the Tour de Suisse, which I had never heard of, from 1955 to 1975. Then they took them and compared them to matched controls with the same exercise level from 75 until the end of the study. And the people who were in the Tour de Suisse had a 10% risk of atrial fibrillation in their 60s. In that small series, they had no one in the control group. Typically, you have about a 1% incidence at age 60. So there is definitely a phenomenon of atrial fibrillation from overconditioning. Don't worry, most of us can't do it. It is 2 hours a day for decades. It's a dose-response curve. So you look at the meta-analysis on the right, or I'm sorry, accumulation of studies on the right. So if you look at 2,000 to 9,000 hours, and that's an hour 5 days a week, it's 9,000-ish for 30 years. They're at maybe a little bit increased risk. To get beyond that, you have to be 1 to 2 hours 7 days a week for 30 to 40 years. It's typically cyclists, rowers, and people like that. Somewhat runners, although most runners who run 2 hours a day for 30 years are no longer runners. They're cyclists and other things like that. But it doesn't usually happen for weightlifting and other things. And this in Montreal has been teased out by an animal model. If you overcondition rats, so if you run rats on a treadmill an hour a day, 5 days a week for a period of weeks, and then you do electrophysiology studies, you see changes, again, similar to what we see in AFib patients, including an increase in inducibility of AFib. A normal rat is very, very hard to induce atrial fibrillation because the heart is so small. Now, these effects are blocked by atropine, which we don't see in humans. So there's something in the long-term risk of atrial fibrillation that's slightly different from this model, but hopefully it will be teased out over time. So more and more we want to move away from the concept of lone atrial fibrillation, which we used to think of as AFib from no disease, just by itself. We want to start thinking about these other conditions that are playing a role in triggering the atrial fibrillation other than coronary disease, vascular disease, diabetes, et cetera. So let me switch back for a second to go through a couple other things. Maybe this will go better than it did last time. So I want to give you a couple of updates on atrial fibrillation and start with the Watchman device, or atrial appendage closure. I don't know if any of you guys have heard of this or talked about it. Sorry for the people who are listening remotely. I'm going to hand around one of the Watchman devices as we talk. So what we know is that there are a lot of people who have atrial fibrillation and risk of stroke who do not get anticoagulated. Having atrial fibrillation alone increases your risk of stroke somewhere between 3 and 5-fold beyond people with the same risk factors. And we know from small studies that most of the clots from atrial fibrillation form in the left atrial appendage, about the size of my thumb, hanging off the edge of the left atrium. And for some reason, despite the newer anticoagulants, we're still only anticoagulating a little bit more than 50% of the patients who have atrial fibrillation and risk factors for stroke. And in addition to the fact that many people are not anticoagulated, some people are very hard to anticoagulate. They're never within the target range, they can't afford the newer agents, or don't want to take the newer agents. So there are a lot of patients who are underserved who has risk factors for stroke. And in addition to this, the concept of appendage closure was forwarded because of the risk of bleeding on anticoagulants. So as you all know, there are some people who have risk factors for stroke, may have tried an anticoagulant, but bled so severely that they are not anticoagulatable or cannot be anticoagulated long term. And the percentage of patients anticoagulated does not go up based upon the risk of the patient for some reason. This may have to do with the comorbidities. If you have a CHAD score of 6, you're a pretty sick, usually old person. So those are the very people that are hardest to anticoagulate. So back in the late 2000s, one of the companies came along with the idea of closing off the left atrial appendage with that device you see there. The way this device works is it is deployed percutaneously in the neck of the left atrial appendage. It endothelializes over a period of a month or two and basically excludes the left atrial appendage. First studies showing this work came out in 2008, and the FDA decided not to approve it, so for some reasons I'm going to show in a minute. So we've been experimenting on Europeans for the last 7 to 8 years. There have been 10,000 of these placed in Europe with no clear signal of excess harm, although clinical experience is not quite like randomized trials. It is a device that comes in various sizes. I show this partly to highlight that somewhere between 5 and 10% of people have an appendage that is the wrong size. So right now we don't have devices to fit every patient. We screened somebody 2 weeks ago. They have a 35 millimeter opening to the left atrial appendage. The biggest device is 33. So it's just not possible. And again, that's 5 or 10% of patients. So in people who have risk for stroke and high risk for bleeding, they can be implanted with the Watchman device. Now, whether that prevents stroke as well as anticoagulation is not entirely clear and is extraordinarily confusing. So this was not approved in 2008, partly because of a signal of possible excess procedural risk. The FDA mandated another study by new operators at new centers, and the procedural risk seems to have been mitigated, gone down by more than 50%, but it's not as clear that it prevents stroke as well as anticoagulation in someone who is anticoagulatable. And so if you look at the first study called the PROTECT trial, first of all, they were patients who were on warfarin who were very unlucky. So of the contemporary warfarin trials, they did pretty badly. It wasn't that they had mismanaged. It wasn't their therapeutic range was terrible. They just had more bleeding, intracranial bleeding, and so the device was very, very effective compared to that. It did seem to decrease stroke compared to other studies, but the fact that it decreased it a lot in the initial trials compared to that warfarin group doesn't necessarily prove that it works. Again, works compared to warfarin, although it seems to be a heck of a lot better than doing nothing. They had, in the initial trial, a slightly increased procedural complication rate. They redesigned the device, and then in multiple other series, so this is the first trial, the first half, there's a complication rate of 10%, which was unacceptable. That was 2008. All the studies since have shown a complication rate of about 4%. And a lot of that was the device was changed, the delivery system was changed, and there was a worldwide learning curve on how to do it. They also mandated, as we have with the rollout here, that you need a team who can cross-pollinate. For example, the stent doctors don't spend any time in the left atrium, and the EP doctors spend all their time in the left atrium, but they don't deploy devices. So what we've done, as most centers, is we have 2 people co-scrubbing and a specialized team of echo doctors who do all the measurements for this. So that seems to hopefully have made this issue of procedural risk go away. As I mentioned briefly, but don't have time to cover in detail, if you look at the PROTECT trial and the second trial is the PREVAIL trial, we had differing stroke rates. So the second trial, by the way, this was very, very unlucky. The second trial they did, the warfarin patients did better than any other warfarin trial ever in the history of AFib treatment. So guess what? The device was worse. If you split the mean, which is statistically dishonest, if you split the mean, they did about the same. But if you take the first trial, they beat it like crazy, and the second trial, they did not do it well. So that leads to, and I want to come to the indications for the device, that leads to Medicare indications, and this is a little bit confusing if you Google it. You want to look at the Medicare indications because the FDA indication, the company indication were a little bit more broad, but you don't get it paid for if you don't have the Medicare indication, is that patients have to have a CHAD score 2 or more, CHAD VAS score 3 or more, non-valvular atrial fibrillation. You have to document in the chart, this was new to me, that you've had a shared decision with the patient, and you have to use a validated tool. So I use one called healthdecision.org. It shows little people that have bleeds and people who don't have bleeds, people who have stroke and people who don't have stroke, and then you can print it, scan it into the chart, and give it to the patient. There are tons and tons of these tools, but you want to clearly document that you didn't just say to the patient, you need X, I'm signing you up, you're done. You need to know that they've participated, and this is starting to happen around all of medicine. And then here's the part that was not entirely expected. You have to have patients who are suitable for warfarin but unable to take warfarin long-term. Unable. So they have to be somebody. So the first patient we have is scheduled May 19th. She's a woman who had coronary disease, prior CABG, permanent atrial fibrillation. She was put on anticoagulation last fall. She had a hospitalization at 3 packed red blood cell unit requiring GI bleed. Got hospitalized again, also for a transfusion requiring GI bleed. They stopped her warfarin. She showed up with a stroke. Unfortunately, this is AVMs that can't be reached, so she has a non-reversible cause of GI bleed. The gentleman I just mentioned, who had a 35, had also had CHAD VAS score of 6, 2 GI bleeds within 6 months requiring blood transfusion. The gentleman I saw yesterday had a mini stroke and intracranial hemorrhage. So the problem with the intracranial hemorrhage group is some of them can be anticoagulated short-term, some of them cannot. And so then we grab expertise from neurologists and neurosurgeons to decide which one. So if someone fell because they were tripped by their dog, while on warfarin INR 4, you can put them on warfarin for a short period of time without it being a big risk, maybe even long term. And in addition, which may be reassuring, these patients have to be enrolled in a registry to make sure that we're doing what we expect to be doing. One part I want to highlight is that they have to be on warfarin for 45 days around the device because I mentioned before, it endothelializes over the first 1 to 2 months. Until it endothelialized, it might be slightly thrombogenic. There's little screw holes and other things about it that are even worse nooks and crannies than an atrial appendage by itself. So I'm going to stop there in the interest of time. Do you guys have any questions? Or?
When you put them on warfarin,
yeah.
Number of visits per week?
Well, it's more similar to a gym. They're supposed to try and come in a couple times a week, but not regulated. General guidelines, not necessarily regulated. That's the same criteria we have as we use other cardiac patients. Andrew? No, and unlike things like hypertrophic cardiomyopathy where you can decondition and change the heart thickness, this is often after many decades of use. And if you've done 2 hours a day for 30 years, you're never going to get them to stop exercising. The only part that I can say, which is reassuring but won't show, they are very, very responsive to therapy. So their single procedure, their 2 procedure success rate is like 95%. First is like 70%. So they do, and they tend to do, unlike the obesity, you may or may not have noticed, those obese patients, sleep apnea patients, the curves over time just kept going downward. The people who are very fit, if they're successful at 6 months, they're usually good. So you really seem to be doing away with the disease cells.
That's good, yeah.
Right? Yeah. Thanks.